Bismillah ar-Rahman ar-Rahim. I am Dr. Walid Elrewihby, a nephrology consultant at the Manhour Medical National Institute, Egypt. My talk today about acute kidney injury in hospitalized patient during a Muslim pilgrimage, Hajj 1432. Our study was published in the Saudi Journal of Kidney Disease and Transplantation 3 years ago. As all we know, Hajj is a principal religious obligation for any able adult Muslim who can afford to do so. And according to the Central Department of Statistics and Information, the total number of pilgrims for the year 1432 was about 3 million pilgrims. About 1.8 million arrived from outside the Kingdom of Saudi Arabia, and the rest came from within the kingdom. And we think that these figures are unparalleled to any other universal mass congregation. Most studies already focused on Hajj pilgrims have focused on heat-related disease and infectious disease only. And to our data, no available studies focusing on the occurrence of acute kidney injury in this group of patients till this date. Also, there is no statistics about the acute kidney injury effect on the outcome of patients during their hospitalization. We aimed in this study to evaluate the prevalence of acute kidney injury and its etiology with the associated risk factors among hospitalized patients during the Hajj time. Also, we aimed to compare the analysis for the use of slow continuous therapy for patients with hemodynamic instability versus the conventional hemodialysis therapy on the patient outcome. This study was a retrospective observational study and done between the Islamic lunar dates from the 1st of Dhul Qa'dah to the 29th of Dhul Hijjah in the year 1432. It was held at the King Abdulaziz Hospital. It is a 250-bed tertiary care hospital in Mecca, and it is one of the 4 main tertiary care hospitals in Mecca city that serve pilgrims during the Hajj time. Actually, 851 pilgrims patients were admitted to the hospital at that time, and 87 patients, about 10%, developed acute kidney injury, either before admission or during admission to the hospital. The mean age was 60 years, plus or minus 9.2, with a predominance of males, about 75% males and 25% females. About 55% of our patients were admitted to the medical ward and 30% to the ICU, and the remaining 15%, about 15% of our patients admitted to the surgical ward. This table shows the main characteristics of our patients. And this table shows the primary cause of admission to the hospital. It was mainly due to infection. More than 50% of our patients admitted due to infection, either due to pneumonia in 32% of our patients, or skin-related infection in 10%, or gastroenteritis in about 5%, and acute abdomen about 2% of our patients, and the remaining 50% due to diabetic complication, renal disease, cardiovascular disorders, anemia, liver disease, and traumatic fractures. This table shows the associated comorbid diseases to our patient. It was mainly due to hypertension, with hypertension, 70% of our patients, diabetes in about 60% of our patients. Also, other comorbid diseases like chronic obstructive lung disease or chronic kidney disease, ischemic heart failure, liver diseases, or all the strokes in our patients. This table will divide our patient to 2 groups according to the need of hemodialysis or not, or type of hemodialysis. So we found that about 75% of our patients didn't need hemodialysis during admission, and even with developing acute kidney injury, and about 16% needed conventional hemodialysis due to their hemodynamic stability, and about 8% underwent continuous renal replacement therapy due to their hemodynamic instability. This table shows the outcome on discharge of all patients according to the need for renal replacement therapy during admission. According to the two groups, in the group who need renal replacement therapy, we observed that renal function improved in about 52%. And in the other group who didn't need renal replacement therapy, the improvement was in kidney function was 62%. And death, it was 28% in the group needed hemodialysis and 30% in the other group without significant difference between both. This study is, to our knowledge, the first study evaluating the incidence of acute kidney injury in Hajj pilgrims. And the incidence of acute kidney injury accounted for about 1/10 of all admitted patients to the hospital. And the age of patients were similar to previous studies in Hajj pilgrims. And we didn't find increase in mortality during hospitalization among patients with past history of comorbid disease like diabetes, hypertension, and other comorbid disease. Infection was the main cause of admission for patients who developed acute kidney injury, mainly like pneumonia, as we said before, 32%, or skin infection, followed by renal disease, about 15%. We found also no significant difference in mortality, rate of recovery of kidney function, or duration of renal replacement therapy between the two groups who received conventional hemodialysis or slow continuous renal replacement therapy due to their hemodynamic instability. So in summary, infection was the main cause of admission for patients who developed acute kidney injury in our hospital, and the type of renal replacement therapy used had no different effect on the outcome at the time of discharge. Our observations that maybe help that adequate fluid resuscitation in emergency rooms can help in reducing the high incidence of acute kidney injury among pilgrims during Hajj time. We hope that this data will help the healthcare planners, administrators, and officials to improve the healthcare services to Hajj during Hajj, to pilgrims during Hajj time. Also, prospective studies are needed in the future on acute kidney injury between pilgrims during Hajj time. And lastly, I hope to thank you for listening to us.